I'd like for everyone to think for a moment about the value of human life. And does one person's life have any more value than another person's? The current fee-for-service healthcare system rations out care based on the patient's ability to pay. I believe this is unethical. It is criminal. 95% of the country is still functioning on this fee-for-service model. I believe everyone should be treated the same. Everyone should have access to primary care regardless of their ability to pay.
Hi, I'm Dr. Faisel Syed. Welcome to another episode of Faisel and Friends. We're here because we believe everyone deserves access to quality primary care, and ChenMed needs physicians to take care of them. Tonight's topic is gaming the system for better health. I'm really excited about our friend that we have joining us tonight. I think he's brilliant, and I believe that he has ideas with his platform that we can change health. We can make improving behavior in health a fun thing for our patients to do. So Dr. Dan, my co-host,
hey,
moderator.
Yeah, hey Faisel, this is great to be here tonight. Looking forward to getting the audience engaged and getting some questions in front of you all.
That's right. We enjoy the interaction. It's our favorite part of this, going live since we started doing this because of COVID. We look forward to coming back out again and doing these events in person. But for now, this is a great way for us to connect with just great people who are passionate about healthcare, passionate about primary care. So without further ado, our friend for this evening, Jake, welcome.
Dr. Syed, Dr. McCarter, how are you? It's good to see you all.
Thank you so much for joining us. I just want to get right into it. I mean, I loved our first conversation. The introduction was made from a Jake within ChenMed. So if you can tell me, one of the things that he said was that in school, when you guys were in school, there was a big Jake and a little Jake. Tell me the story behind that.
That's right. Yeah, Jake Petrini. So we were both in Master's in Health Management program at Harvard. I was a year before Jake. So it wasn't really a size thing. It was really I came first and he came second. But yeah, I was really jealous of Jake. Him and a good buddy from the management cohort the year after me got the leadership fellowship at ChenMed. I think it's wonderful for both of them.
It's great for them, but I think it's better we're the ones who lucked out with people like him, people like you all who are just so innovative and really just thinking outside of the box, especially now with all these newer models of care that are outside of the fee-for-service system. But now, if you could tell me a little bit more, if you could tell me the story behind smoking. Why smoking cessation? What was it that drew you to smoking, and especially with the Medicaid population?
Yeah, for sure. So I tell the story a couple ways, but I started as a health IT consultant at KPMG. Some of my first projects were with large departments of Medicaid along the East Coast, and you start to see some themes, right? And one of the big themes that really kind of piqued my interest in the space is if you have the correct combination of education and income in this country, something happens, right? There's this thick line between whatever that combination is, right? And people above that line, people work very hard to start companies for them, and people work 80, 90 hours a week to connect with them. And you don't see a lot of innovation under that line. So working in the space and, seeing the systems that the departments of Medicaid had, I just remember thinking like, maybe we could do this a little bit better, and just getting fired up, about trying to help. And, as a young consultant, you work with tons of claims data, right? You're an analyst, and I got to see over and over again, like, okay, COPD, tobacco addiction, CHF, tobacco addiction, asthma, tobacco addiction. And it just plays out kind of across the board. So it seemed like a real problem to solve in a hard space where there wasn't a lot of innovation. And, I feel very close to the Medicaid population. So wanted to go do something impactful for them.
Well, you're right. With smoking and tying it with all these different diseases and illnesses. I mean, when you don't have to be a doctor to know that the leading cause of preventable death across the world is smoking. And like you said, with heart disease, I mean, of course, with different cancers, COPD, chronic bronchitis, emphysema, you name it, all the suffering just tied to this one activity. So what's different with what you're doing? Well, explain what's been done in the past with smoking cessation, and then what led you to move away from what's been done in the past.
Yeah, for sure. So pretty much the standard of care in the space for a long time has been, CBT, MI. It's just counseling-based therapy. Obviously, nicotine replacement came along. That helped with quit rates and efficacy of programs. There had been some early literature around the efficacy of financial incentives, but nobody had really been able to do it at an immediate time frame at a very large scale. So you've probably heard of quit lines, 1-800-QUIT NOW or Quit Works or something like that. And we've sort of built the tech and tried to augment the standard of care. And when we first got into the literature in this space, it looked like if we could shorten that period and make it immediate, that we could really drive higher engagement and higher efficacy, in particular for lower income individuals. And I think that we've seen that play out, as we've gotten off the ground with Sincere Health. We see, remarkable engagement and quit rates for lower SES groups. This started as a independent study in grad school. We got very fortunate. Dr. Von Race at the Harvard School of Public Health was a wonderful mentor and advisor throughout the course of the company. I'm just going to shut off my Slack. My tech guys, man, they go 24 hours a day. They don't sleep. But that's a little bit kind of how we got started. And, from the independent study, spurred some really wonderful software. We got some pilots, we got a clinical trial, and it all happened kind of really quickly.
And how did you get, well, before I get into talking about the software
Sure.
and your device, let's talk a little bit more about the psychology here, because that wasn't there before. The financial incentives, I don't think the financial incentives were ever done in any program before.
Yeah, there were a couple large-scale RCTs, in particular in Medicaid. This was probably 2012, but they physically mailed the cash in envelopes to people. And in some cases, it got there 3 months after the behavior had occurred. But I mean, the case study still looked pretty good, right? If you could get $60 to somebody, the promise of $60 to somebody 3 months after it happened, those arms actually were a little bit better than just pure counseling plus NRT. But there's a lot of really new things in behavioral econ that started to permeate other spaces. Obviously, big tech got into behavioral science before everybody else, for better or worse. But we like to think that some of the basic behavioral econ principles, that inform, big tech and how do we get more attention from people. We're in a real attention economy. We like to think that informs our app, right? We're trying to nudge people in a healthy direction and do something that's good for them.